Welcome to the American Pharmacists Association podcast series on vaccine co-administration and lifelong vaccine strategies for adults. This is part 3 of the podcast series, and we will be reviewing the clinical guidelines and recommendations for vaccination of pregnant patients, with a focus on co-administration of vaccines in patients who are pregnant. My name is Lauren Angelo. I am an associate professor in the College of Pharmacy at Rosalind Franklin University. I'm joined by Cherokee Layson-Wolf, who is a professor at the University of Maryland School of Pharmacy. We are both immunization trainers and have been involved in various aspects of vaccinations for many years. In fact, Cherokee and I have worked together in various capacities for over 10 years. Cherokee, how about we start off with which vaccines are recommended in pregnancy?
Thanks so much, Lauren. There are 4 that we'll spend most of the time talking about during this podcast: flu, COVID 19, Tdap, and now RSV. First off, we have influenza. If a patient is pregnant during flu season, flu vaccine is recommended and can be given in any trimester. In fact, if mom to be is in her 3rd trimester just prior to flu season, it's okay to give the flu vaccine a little bit earlier than recommended for the general population, which would be in probably July or August, so long as the vaccine is available at the pharmacy. This is to ensure that mom and newborn baby have adequate protection against flu during that critical time frame when flu rates are high. If she is in the 1st or 2nd trimesters at the start of flu season, we should wait until September or October to administer the flu shot, as we would with our other patients.
Okay, Cherokee, so this does tend to be a point of confusion, so I just want to clarify. Ideally, we administer the flu vaccine in September and October to the majority of our patients. And this would include pregnant women who are in the 1st or 2nd trimesters. But what you are saying is if our patient is in her 3rd trimester, we would want to get that vaccine on board earlier. So we may actually do that in July or August to help protect newborn baby during flu season.
Absolutely, Lauren. And just like the flu shot, the COVID 19 vaccine can also be given anytime during the pregnancy. While this is a newer vaccine, current evidence has shown that COVID 19 vaccines during pregnancy is safe, and there's ongoing monitoring for evaluation and safety, and receiving the vaccine actually outweighs any risks. For example, COVID 19 vaccine can help reduce severe illness and prevent against other severe effects of COVID 19. It can also help prevent preterm delivery and stillbirths. Protection may be passed on from mom to baby to help protect them in the early months after being born. As with other respiratory illnesses, pregnancy is a risk factor for severe disease and hospitalizations. So, now that we've reviewed when COVID 19 and flu vaccines are administered, let's actually talk about the other 2 vaccines that have a specific timing in pregnancy that we should be aware of. So, first, we have Tdap, which consists of tetanus, diphtheria, and acellular pertussis, and is actually given between weeks 27 and 36. This is the optimal time to allow for maternal transfer of antibodies that will provide pertussis prevention in newborns who are too young to be vaccinated with DTaP. So, second, Lauren, now we actually have new recommendations for RSV vaccine in pregnant patients.
Absolutely, Cherokee. We do have new vaccines for RSV with specific recommendations for our pregnant patients. And so one important thing I want to point out before we dive into the RSV vaccines is while we have 2 vaccines on the market, only one is currently indicated in pregnancy, and that's Abrysvo. This particular vaccine is given to moms who will be between 32 and 36 weeks pregnant during respiratory season. So that would typically be during the months of September through January, when those RSV cases are generally the highest. So just like you mentioned with Tdap, this timing allows for the most optimal protection of the newborn during the late fall and winter months. The goal is to provide that protection via maternal antibody transfer. When mom receives the RSV vaccine during this time frame, protection is passed on to the baby for about 6 months after the baby is born. And we want to note that the vaccine formulation and dose for pregnant women is the same as that for adults who would get the vaccine at ages 60 years and older. So there is another vaccine called Arexvy, which has not been approved for use in pregnancy. It's important to not confuse these products. So make sure in your pharmacies these are clearly labeled, and perhaps even separate them within your pharmacy fridge and stock section. So with regard to timing, as we think about respiratory season and respiratory diseases, with RSV, it's similar to when flu and COVID-19 vaccines may need to be given to our patients.
Lauren, you mentioned 32 to 36 weeks is the recommended window for RSV vaccine. Didn't the trials begin at 24 weeks?
Yeah, that is a good point, Cherokee. When they were doing the clinical trials, they began vaccinating at 24 weeks, so a little bit earlier than the guidance we're using now. But the FDA and the ACIP, or the Advisory Committee on Immunization Practices, decided that beginning at 32 weeks was a better approach. And this was based on two potential benefits that was seen using that narrower and later window in the pregnancy. So the first benefit was there was a slightly better efficacy in terms of the medically attended RSV and severe RSV, lower respiratory tract infections in the newborns when mom was vaccinated in that 32 to 36 week interval. And there was also less concern about preterm births using that latter time period. And then another interesting layer to all of this is we recently had nirsevimab, which is a monoclonal antibody, approved for use in infants to prevent RSV, lower respiratory tract disease. So a common question we get is, should mom be vaccinated while she is pregnant, so that maternal vaccination, or do we wait and give nirsevimab when the baby is born? And so if you look at the CDC's recommendations and the MMWR regarding RSV vaccine use in pregnant women, at the bottom of that, they have a nice little pro and con list to help us determine which direction to take. So advantages of using the maternal RSV vaccination, it would provide that protection immediately after birth. And there is some thought that it might be more resistant to potential mutations in that F protein when we're talking about RSV. The reason we might not do RSV vaccination in pregnancy is there's protection potentially reduced if fewer antibodies end up being produced by mom and transferred to the baby. Sometimes that can happen if the mom who is pregnant is immunocompromised, or if she ends up getting birth too soon after that vaccination. And that window is typically within 14 days. So if she got vaccinated and it hasn't been 2 weeks and she gives birth, we might want to consider then also giving nirsevimab, or if there isn't time to give the vaccine, we would consider that monoclonal antibody. So those are just things to think about. The list is a little bit longer that the CDC provides. A lot of times it could come down to cost differences as well as availability. Right now, there's a nirsevimab shortage that we're currently experiencing, and so we may see increased demand of that maternal vaccination. And so as pharmacies, we will need to be prepared to vaccinate pregnant women if they're looking for that vaccine. And the other thing to think about is what we're trying to accomplish in that goal of maternal antibody transfer when we give the RSV vaccine to mom. So again, there may be times when a pregnant woman gets the vaccine, but the newborn may still need that nirsevimab. And so these are things you'll want to talk to your patients about, especially when we look at that timing.
Thanks so much, Lauren. That was a great overview of really new information. So, hopefully, our listeners would be able to apply that to their practices and be able to answer questions related to that new vaccine. So, we've actually spent a lot of time discussing respiratory vaccines needed during pregnancy. There's many other vaccines that are actually routinely recommended for adults based on age or risk that may also be administered during pregnancy if indicated and after evaluating risks and benefits. So, just some examples of those include hepatitis A and B, meningococcal, and polio. The American College of Obstetricians and Gynecologists, or ACOG, recommends pneumococcal vaccines in pregnant patients who are actually at risk for pneumococcal disease, and Hep B for those who are not previously protected. CDC, immunize.org, and ACOG have helpful resources and guidelines for vaccinations during pregnancy.
Thank you, Cherokee. And we're going to actually refer you to some links that we have available on the learning management system for those resources. We have found them super helpful in terms of how to have conversations with our pregnant women and what vaccines are recommended during pregnancy, which ones to consider based on those risk factors. So we do refer you back to the enrollment landing page where those links can be found. So I want to get back to, we're talking about co-administration and timing and pregnancy. And so if we think about all the different things we're we're talking about, depending on timing, a patient could feasibly be receiving at least 4 vaccines at the same time. Cherokee, are there any concerns about that?
Certainly, Lauren, I could understand how pharmacists may have that particular question when they're having a patient in front of them with multiple vaccination needs. So, receiving multiple vaccines at the same time for a pregnant person is similar to co administration of vaccines in our other patients. So, we would actually still follow the same procedures for multiple vaccines during that same visit. And some of my colleagues have expressed concern about this and the number of vaccines given to patients at one time. But think about Tdap. That alone is people getting 3 vaccines to a patient, and that hasn't necessarily raised any concerns and certainly made it a lot more convenient for a patient to be protected against those 3 different conditions. And young kids also get multiple vaccines, especially combination vaccines during their pediatrician visits. For adults and pregnant patients, there's really no difference. Co-administration of necessary vaccine help protects the mom and the new baby. And any delays in vaccination would in turn delay protection. So when administering multiple vaccines during the same visit, we just want to make sure we separate the injection sites by at least 1 inch and consider administering the vaccines in separate limbs if there's an increased likelihood of that local reaction from the vaccines. For IM injections, the deltoid muscle and anterolateral thigh are all options, even in adults. So, there are some concerns that patients may have regarding vaccines and whether or not they're safe during pregnancy. So, Lauren, for all those vaccines that we discussed, we know they've been found to be safe and effective during pregnancy, and benefits outweigh the risk to mom and baby.
Yeah, Cherokee, that's absolutely true. And when new vaccines come to market, the manufacturers often include a pregnancy registry for the vaccine. These pregnancy registries are research platforms that collect information about the effect that vaccines received during pregnancy may have on the pregnant woman or developing fetus. Some pregnancy exposure registry studies also collect information about newborn babies for a period of time after birth. Your patients can volunteer to join a pregnancy exposure registry if one is open and enrolling.
Lauren, thanks for sharing the information about pregnancy exposure registries. So, what about the adverse effects that we typically expect from vaccines? Is that a concern when we're administering multiple vaccines, especially in pregnant patients?
So, Cherokee, that's a good question. And there are no recommendations against receiving all of these recommended vaccines in pregnancy when they are administered at the same time. However, to your point, it would be important to inform the patient of potential local and systemic side effects. So, while these may be a bit more pronounced when multiple vaccines are co administered, it may be better for the patient to just get it over with, like a once and done approach, rather than have a sore arm, headache, or flu like symptoms on multiple occasions if they're returning for vaccines at a later time. So it's just something to think about and discuss with your patients who need multiple vaccines during one particular visit. So, while we may want to reduce discomfort of our patients, another benefit of co administrations of these vaccines is convenience. The patient would just need to visit the pharmacy once to be protected instead of having to return to receive vaccines at multiple different visits. So, if for whatever reason not all vaccines were administered together, how long should we wait in between each vaccine?
So, Lauren, technically, since they're all inactivated vaccines, there's no specific time frame that we have to wait between visits, but what we risk is delayed protection. But having said that, we just discussed the main vaccines recommended to be given during pregnancy, but there's some that should be delayed until after pregnancy. Live vaccines are contraindicated during pregnancy, and for example, while flu vaccine is recommended during pregnancy, we would actually give inactivated flu vaccine and not live flu vaccine. Other live vaccines like MMR or varicella are also contraindicated during pregnancy, but should be given right after delivery if the pregnant patient did not have protection or evidence of immunity before the pregnancy. And lastly, HPV, while not a live vaccine, should not be given during pregnancy.
Okay, but quick question. If we're administering vaccines like MMR and varicella, which are those live vaccines, right after she gives birth, are we worried about breastfeeding in the newborn baby?
Great question, Lauren. And actually, according to the ACIP, there's only 2 vaccines that should not be given to breastfeeding women: smallpox and yellow fever. All other vaccines, both live and inactivated, pose no risk to the new baby who's breastfeeding, and all routinely recommended vaccinations that a new mom needs can and should be actually administered even if she is breastfeeding.
Thank you for clarifying that, Cherokee. And that's great information regarding live and inactivated vaccines. So I'd now like to take a moment to address how to identify which vaccines a pregnant patient needs. It really comes down to timing. We spent a lot of time talking about Tdap and RSV, as well as respiratory diseases. And so, what we'll need to do as pharmacists is ask our patients how far along they are in their pregnancy to determine their vaccination needs. So, like Tdap and RSV, we need to know what weeks and if they're in that third trimester. Or it might be based on time of year where we are offering other respiratory vaccines like influenza and COVID 19. And remember that third trimester is really an important time. So knowing where they are in terms of weeks presents a great opportunity to schedule appointments for Tdap and RSV if those vaccines are going to be needed later on in the pregnancy. And it's always a good idea to collaborate with your OB and GYN offices to evaluate your patient's vaccination needs. And we can make offers to vaccinate if those offices don't stock particular vaccines that the pregnant woman might need.
And thanks, Lauren. And before we finish up, we wanted to share some resources that can help you navigate the vaccination needs for pregnant women. These resources will be available on the landing page for this podcast, so please be sure to visit them so easy access for these resources. The CDC has specific guidelines for pregnant women, and they also offer information for vaccine safety for mom to be. They also offer various flyers and infographics to help inform your pregnant patients on vaccination needs and benefits. You can also check out the Immunization Action Coalition at immunize.org and the American College of Obstetricians and Gynecologists, or ACOG, website at acog.org. Thanks so much, Lauren. This was definitely a great conversation and hope it helps our audience with understanding vaccination needs in pregnancy. This concludes our third podcast in the series. If you haven't done so already, please check out the other two. We thank you for joining us and we're so grateful for all that you do to help keep your patients and our communities healthy.